This is our second scientific section, and that is a description of research on mood, anxiety, stress, and sleep. Those are certainly related conditions, and we have very strong emphasis on these both now and historically in our department. The first talk from this section will be from Murray Stein. He's a distinguished professor of psychiatry and family medicine and public health. He's vice chair in our department for clinical research. I think, personally, that through his work in DSMs as well as his very impressive work on anxiety, including stress disorders as well, I think he's perhaps the leading, if not leading, one of the leading people in his field in this country. And we're very, very lucky to have him. His work has been in neurobiology, treatment, underlying causes, social anxiety disorders, post-traumatic stress disorder, and TBIs, traumatic brain injury. So Murray's going to give a talk on getting past post-traumatic stress disorder. Looking forward to it. Come on up.
All right, good afternoon, everybody. Glad to be here. I'm going to jump right into the talk. So I'm going to talk, and I think a couple of us in this next session are going to talk about post-traumatic stress disorder, so I figured it'd be worth spending a couple of my precious 15 minutes on that. PTSD is really unique in some ways among psychiatric disorders. So it's really interesting that in psychiatry, in the way we teach and the way we think about mental illness, most of us think about a biopsychosocial approach to the way illnesses develop and their etiology. But if you look at DSM, and maybe you don't want to look at DSM, but if you do, PTSD is really the only disorder where it talks about a particular type of stressor causing the illness, right? So you can't have PTSD without a traumatic event. And if you think about other disorders where we think a lot about stressors having precipitated illness, like depression, it's not part of the diagnostic criteria, but it is for PTSD, which makes it, I think, really interesting to study, but also in some ways difficult to study. So PTSD involves exposure to sort of a horrific event, something that threatens people's lives, changes their lives in not good ways. And, you know, this can occur by people directly experiencing a traumatic event. For example, somebody's held up at gunpoint, they think they were going to get killed. They weren't, but they have symptoms as a result. But it's also a really interesting disorder because you could develop PTSD not having been the person who was held at gunpoint, but you were walking down the street and literally across the street you saw somebody else held up at gunpoint. You could, as we humans can, imagine, wow, that could have been me. And you could develop PTSD from that, at least according to DSM. And there's these different gradations of exposure that wind up interacting with one's predisposition to developing mental illness after stressors. That makes this, I think, a really interesting problem to try and tackle. So for example, you know, if you're a chicken, this could be a traumatic event that could give you PTSD. And the way we think about risk for PTSD is really multifaceted. And what I'm going to do in the next 12 minutes or so is focus just on a couple of areas that I think are interesting and involve work that colleagues and I have been doing. But this is sort of an overarching schema of one way to think about PTSD. So trauma is there at the forefront. You've got to have it in order to develop PTSD. Different types of trauma matter. Childhood maltreatment, which I'm not going to talk about, is a risk factor for virtually every psychiatric disorder, and then can be associated with increased trauma exposure later on in life. And then there are all these other factors that increase risk, or if you flip them around, are protective. But having a personal history of a depressive or anxiety disorder and then being exposed to life-threatening trauma increases your risk for getting PTSD. family history of an anxiety disorder does, and as I'll talk in a minute or two, some specific genes might as well. Women are at increased risk, just as they are for depression and most other anxiety disorders. We don't understand why. But another way to think about PTSD is, given trauma and given these various risk factors, people fall into some hierarchy of likelihood of developing PTSD symptoms. And what we do, and we do this with many of our psychiatric disorders, we sort of draw a line and say, if you got more symptoms than this, you have the disorder. If you have fewer symptoms, you don't. And of course, that's not reality. People here really don't differ much from here, either in terms of their functioning or possibly in the way we should treat them. Another factor that seems to relate to PTSD is whether or not somebody was physically injured, and particularly if that injury involved the brain. And I'll talk a little bit more about that. And I won't talk about that. PTSD, again, like many of the disorders you're going to hear about over the next couple of days, rarely occur alone. So we spend a lot of time teaching and talking about trying to come up with, the single best diagnosis for an individual, but most people we see and treat have multiple disorders. And these are some of the disorders that tag along with PTSD a lot of the time. So major depression, about 2/3 of people with PTSD are depressed when they present. Many develop substance abuse problems. Chronic pain goes with PTSD, as does traumatic brain injury. So I'll spend a minute talking about mild traumatic brain injury or concussion, which, as you know, can occur in a military context. It can occur in a sports injury context and other sort of civilian settings. This is some work colleagues and I did as part of a study called Army Stars, where we were given really unprecedented access to a group of soldiers who were about to deploy to Afghanistan. And we did this with 3 combat brigade teams and are focusing here on a little less than 5,000 soldiers that we were able to follow longitudinally. So we were able to talk with these individuals and get information about them and have them complete a number of survey questions before they were deployed to Afghanistan, and then shortly after they came back, 3 months later, and 9 months after that. What we found out was during their deployment, about 20% of soldiers reported that they'd experienced a mild traumatic brain injury or a concussion, and a few actually had more severe injuries. And that's pretty consistent with what was happening in Afghanistan around the time, so 1 in 5 soldiers. When we looked at those individuals who'd been exposed to traumatic brain injury, even when we adjusted for all the many other factors that we know and found in this study are associated with increased risk for mental disorders, we found that having been exposed to mild traumatic brain injury markedly increased the risks for developing a whole host of psychiatric disorders, including PTSD, including major depression, including generalized anxiety disorder. And this diagram shows that, again, it was rare for an individual just to develop one disorder. Most people would develop PTSD and major depression and GAD and so on. But there was something about having a traumatic brain injury that increased the risk for mental disorders. And this is a finding that had been shown prior to this and has subsequently been replicated a number of times. So, what might be going on that traumatic brain injury would increase risk for mental disorders? And part of it may have to do with concussions, particularly the regions that are affected by the traumatic brain injury, which frequently will involve frontal cortex, dorsolateral prefrontal cortex, but possibly also shear and disrupt connections to deeper areas of the brain as well. I'll come back to that. I've had the privilege over the past couple of years of working with colleagues around the country on a study called Track TBI. Jeff Manley, who's a neurosurgeon at UCSF, is the PI, and I'm kind of the team psychiatrist for this project. This is a study where they have enrolled from emergency departments close to 3,000 individuals who were then followed prospectively after a traumatic brain injury. All of the people here showed up in an emergency room, gave a history consistent with traumatic brain injury. The emergency doc thought enough of it that he or she ordered a CT scan on everybody. So we've already kind of got a level of likelihood of having a TBI. And then they're followed prospectively. And so we've focused on some of the mental health outcomes related to these mild traumatic brain injuries with individuals who've had other non-head orthopedic injuries as comparison subjects. And so these are some of the findings. This is looking 3 months post-concussion. What are some of the mental health outcomes among the individuals who had a mild traumatic brain injury compared to the orthopedic control group who had an injury that got them to the ED, often hospitalized, not always, but no CT scan and low likelihood of having the brain involved. You can see that if you look at 3-month major depression, the individuals who had mild TBI have close to 9% rates of major depression compared to 3% in the orthopedic injury. If you look at PTSD, close to 1 in 5. Half the number among those with orthopedic injuries. So again, another finding, another replication here in a non-military setting of having a TBI increasing your risk for a number of mental disorders, PTSD among them, but not the only one. And if we take a look at risk factors, so if you got a TBI, what is a risk factor for developing PTSD or not? Well, one of them is lower education. That's been a widely replicated risk factor for PTSD. This was sort of still inexplicable to us because we looked to see whether, so African Americans were at increased risk. We adjusted for other sociodemographic factors and still couldn't make the finding go away, so that's still a puzzle. Not surprisingly, if somebody had mental health problems before their traumatic brain injury and then had a concussion, they were much more likely to develop PTSD. The nature of the injury mattered, and this probably shouldn't be a surprise either, but if they got their TBI by having been assaulted, they were much more likely to have PTSD than if they had it in sort of a more random injury like a motor vehicle collision. And then there'd been MRIs that were done 2 weeks and into the study on all individuals. And we haven't published any of this yet, but we've actually found that having smaller superior frontal volume of the brain or smaller anterior cingulate volumes, and actually both of them are additive, the smaller these were, the greater the likelihood of developing PTSD. And so we're following up on that as well. Talk briefly about genes. I apologize, this one's actually a Jean. Actually, I guess that one is too. So I want to talk for a minute about the Million Veteran Program. This is a nationwide VA study that, again, I've been fortunate to be able to be involved with. It involves veterans at all across the country at a number of sites agreeing to give a blood sample from which DNA was extracted and genotyping's been conducted. And they've also given permission to link to their electronic health records, and many have also completed surveys, a lot of which have a lot of information about mental health problems and things that we're interested in. So really a remarkable resource. Just sort of jump to what we've done. We've done work in PTSD, in this case doing a genome-wide association study. And this is a Manhattan plot looking across the 22 autosomes to see whether there's an association with any particular variants in genes and the outcome of PTSD. This is the single largest PTSD genetic study done in terms of all coming from a single sample and all being genotyped and phenotyped in the same way. Our diagnosis actually comes from an electronic health record algorithm that we and colleagues have developed, and it works really well. So close to 50,000 patients with PTSD and close to 200,000 controls gives us these two interesting genome-wide significant hits. I'll talk a little bit more about those. But as I pointed out before, Yes, you can think of PTSD as being a binary disorder. If you'll remember that sort of histogram, if you're to the right of the line, you got lots and lots of symptoms, you got the disorder. If you're to the left, you don't. Well, if we really don't believe that that's the way this works and the way biology works, then it might be more interesting to actually look at severity of symptoms within individuals. And according to DSM and ICD-11, these are the core traits of PTSD. You've got avoidance, you've got re-experiencing symptoms. Re-experiencing really is what defines and distinguishes PTSD from other anxiety and mood disorders. And then you get hyperarousal. And these are just examples of the symptoms that fall into each of these domains. When we take that tact and we actually add up symptom severity among individuals based on self-report, so we're not just looking at cases and controls anymore, we're now looking at a continuous measure of PTSD symptom severity, we find many more genes and many interesting genes that pop up as being genome-wide significant. And won't go through all of them, but one of them, MAD101, also shows up in that binary case control analysis. This is a gene that also shows up in schizophrenia studies and bipolar studies and now even in major depression. So it may be an example of a gene that conveys risk for a number of mental disorders. And then one of the genes that crops up here is CRHR1, which actually is a gene that was an a priori candidate for many, many years. And there's still lots of research going on looking at the possibility that this may relate to the biology of PTSD. But what you can do is you can go beyond just looking at which genes are associated with PTSD or which genes are associated with PTSD symptoms and use bioinformatic tools and refer to other databases. In this case, on the left, you can look to see whether or not expression of certain genes is enriched among the genes that we find in our GWAS. And you can look to see which regions of the body seem to be associated with that expression preferentially. And here, not surprisingly, but you'd be surprised how often you don't find this, that a psychiatric disorder, in this case PTSD, seems to be associated with enrichment of genes that are expressed in the brain. That's a good thing. But then you can go a step further, and this is work done with colleagues at the Karolinska Institute in Stockholm, where I had the pleasure of being on sabbatical last year. And what they do is they can take us not just from what organ, the brain, but actually tell us about which types of neuronal or non-neuronal associations there are with PTSD using the same kind of technology. And what we find here is an enrichment in medium spiny neurons. And that can tell us a lot about regions of the brain that might be important in PTSD, but also to the extent that we know about the biology of medium spiny neurons, it can tell us something about potential biology that would be important for drug targets and treatment. And in this case, medium spiny neurons point us to either dopaminergic agents or GABAergic agents. Medium spiny neurons are themselves innervated by dopamine, and as well as a number of GABAergic synapses. So these, and I think you're going to hear more about this line of reasoning in some of the talks that are coming up. So I just want to end by pointing out that I've been here actually half of the past 50 years, which is sort of both astounding and frightening. And I want to thank the dozens, and it's probably more, of colleagues, students, and mentors that really have made my professional life here be wonderful. As you could probably tell, I love participating in studies that involve lots of people, and I learn from them, and I just think the expertise of big groups and team science is fabulous. I want to thank the funders of our work over the past 25 years. This included the NIH, Department of Veterans Affairs, Department of Defense, and including some private donors. And let me stop there. Thank you.
Thank you. That was fascinating talk, and going from the basic to specific genes to clinical aspects. It's just a remarkable series of research, and he's not the only one here at UCSD. As to finish off with what Murray said, that he's part of a fantastic group here as well.